Well, I will be speaking of the macular hole in different scenarios. First of all, this is a case of a simple macular hole. As you can see, after doing the BVG staining, it's in the high magnification and recite lenses. It's pretty easy to peel the ILM, and we always try to peel it from arcade to arcade, because in case of a failed macular hole, we need to repeel. So in the primary case only, it's always better to peel as much as possible. So this was about the simple macular hole. Now, large macular hole, this is a very common scenario we come across. Obviously, this is a comparatively older video where the inverse peel, we didn't start the inverse fill. So this is one of the methods we can try for a large macular hole. This was epiretinal membrane along with a large macular hole. So once we peel this ILM along with the ERM complex, you can see it's quite a large macular hole. So what we can do, we can actually drain it from the edges of the macula. We need to be very careful. And many a case, we actually can close a macular hole on table, as in this case. A large macular hole actually closed on table. Now, nowadays, what we do mostly is inverted flap technique for a large macular hole. This is what we do. We take the ILM, remove it, and leave it at the edges of the macular hole so that it falls on the macular hole and serves as a scaffold on which the neurosensory retina grows and the macular hole closes. So first of all, the most important part is to keep a small island of ILM along the edge of the macular hole, and then later on we can actually have a concentric peel and increase the area of ILM peeling as to reduce the tangential traction. Can we have the music? last scenario, sometimes the primary surgeon is not. You don't know how much peeling has been done, so actually stay and see how much peeling has been done. And if there's area of the peeling from arcade to arcade. Peeling is technically a little bit difficult process than compared to primary surgery. But if the staining is good, you can easily do. Sometimes multiple staining is required to get a complete once you have peeled from arcade to arcade, you use a little bit of mechanical manipulation of the edges of back. In fact, the last case had a type 2 closure. So this is the different scenario of macular hole, which can be done easily with this newer instrumentation, and especially the weaving system, which allows a much predictable outcome. Thank you.
Excellent, Aniruddha. And have you tried multiple fluid air exchange in cases of failed macular hole?
Yeah. First of all, we see that whether the peeling has been done as much as possible, and then fluid air exchange multiple times actually helps the hole to get closer. And especially if you drain from the edges, it can close on the table itself.
Don't you think it's a little riskier to you drain from the macular fluid from the macular hole?
Yeah, you need to be very careful. I showed
careful.
one video where we could actually close it on table.
Yeah.
Because I think it all depends how much you are seeing. If your visibility is good, the chances of complication is much less, because you can do a precise work.
You have to have a good visualization system. Yes, that's true. And another thing, and how far you want to peel? Let's say primary idiopathic macular hole, how far you want
I
to
generally peel arcade to arcade in all cases.
And what's your choice of inverted peeling versus normal peeling in idiopathic
Nowadays,
macular hole?
frankly speaking, we are doing more of inverted peeling. We don't want to take a chance.
Yeah. Yes, that
But
is true.
anything above 400, 500 microns, inverted peeling would be a better choice.
And to Sudipto, do you think in cases of LMH and the lamellar hole-related epithelial proliferation, do you want to peel ILM as far as he does in normal idiopathic macular hole peeling? Is there any difference in ILM peeling in those cases with epiretinal proliferation?
ILM peeling in LHP.
Yes.
So, see, I think initially we used to do only the membrane removal, leaving intact the ILM. But I think in macular surgeries, if you are getting close to macula, we have a macular pathology, it's always better to handle the ILM also, to remove the ILM. Now, if you want to make a flap or you want to remove in toto, that will probably come with experience. But it's better to handle ILM in these patients.
Okay, so you recommend ILM peeling in those cases?
In all patients. These are actually
I showed all the surgeries in the recite lens, and the macular peeling is done in a high magnet lens, not the contact one, the recite one.
You have a different macular lens by which you can have the opportunity to put a macular lens also, whichever system you have. So our next speaker is Dr. Shubhendu Baralal. He's from Disha Eye Hospital. He's a prolific retinal surgeon, and mostly expertise in subretinal surgeries. Now he'll be talking about macular hole and retinal detachment, how to deal and what are the tips and tricks.
শোনা যাচ্ছে।
And the surgery of for this concomitant macular hole and retinal detachment because different approach from the traditional techniques. Standard approach of handling this kind of disorder in the same patient are standard PPP along with PMD induction, peeling ILM without use of heavy fluid PFCL. So PFCL is somebody can use. I will discuss one by one. Fluid adduction followed by either long-acting gas in ISO expansion concentration or silicone oil as a tamponade. Pre-operatively, it is very difficult to diagnose the macula because the macula is it depends on the elevation of the macula. Sometimes you'll do OCT, but you cannot see the neurosynaptic retina. It is elevated so much. There is so much like height of the macular height. It is so it is not captured. It cannot be captured by the OCT. So these are the few cases where I took the photograph of this macular OCT where the OCT is showing the macular hole, and sometimes even in all macular off cases, retinal detachment, we are not convinced traditionally doing the OCT in each and every macula of retinal detachment cases. So vitrectomy with ILM peeling is an efficient and safe procedure for the macular hole induced retinal detachment, and removal of the ILM contributes to the successful reattachment and is effective treatment for the macular hole and detachment in high myopia eyes. They are already published in Retina 2004. There is no evidence of benefit of ILM peeling in terms of primary outcome, that is the measured BCV at 6 months, and ILM peeling appears to be superior and cost effective in low peeling counterpart as it offer more likelihood of primary anatomical closure. That has already been described by Spiteri, Cornish et al. So you should always remember that it is mandatory to attempt to avoid letting dye pass through the macular holes to come in the direct contact with the RP. That means previously we are using ICG. Nowadays almost very few of us practically we are not using ICG because it is more toxic, and whereas the more safe dye is available, that is BBG. Better to aspirate the ICG if you are using ICG till date at all. So you should aspirate out the ICG with a soft-tip cannula, including that may accumulate under the retinal space and cause damage to the subretinal and cause subretinal toxicity. So why it is very careful not to avoid the direct contact with the RPE cells. Without PFCL, do not expect to achieve continuous macrodexis, patchy removal of the ILM. Rather, it is advised by the it is achieved by the sectors. Another thing is try to avoid the if you are not using PFCL, you have to hold the ILM flap away from the macular hole margin as well as from the peripapillary bundles. If you hold it at the macular margin, that can anyway extend the whole margin also. To avoid excessive elevation of the macular retina during this procedure, and also it is important to minimize the light exposure to cause phototoxicity of the foveal tissue, and avoid the remaining fluid to be withdrawn, avoid the accumulation of fluid at the margin of the macular hole. That will cause recurrence of retinal detachment. Small amount, it should be absolutely dry. So what are the pros and cons of using heavy fluid PFCL? PFCL, it can stabilize the posterior pole, it can exert counter traction. That is the biggest advantage of PFCL, but there is always potential risk of PFCL getting going under the retina through the macular hole. If the whole margin is having some kind of traction because of intrinsic retinal traction or unpeeled membrane, so especially in detachment, the high macular retinal rigidity is very high, and the margin of there is posterior staphylinoma in high myop. In this case of ILM peeling in detached retina, where you can see during vitrectomy also the hole has a little bit enlarged because of aspiration because of the suction induced, cutter induced aspiration through the macular hole. And I've stained the ILM with the help of BBG, and without using PFCL, I am peeling the membrane. Just see that the retina is I am elevating the retina at the macular area, and there is no continuous macularexis. Patchy removal of this ILM is possible, and slowly you have to keep your patients without using PFCL. It is very difficult. It is to peel this kind of ILM from the detached retina. So finally, I have just succeeded to remove all the ILMs, then injecting PFCL to stabilize the posterior pole and doing the fluid exchange from the peripheral brake. This is another case where I am fixing the posterior pole with the PFCL and after staining the ILM, and then using the Tano scratcher to lift up the flap and trying to peel the ILM in a continuous manner, and it is very in a controlled way. You can see, and slowly I am removing all the ILM around the macular hole. It is not mandatory to make the whole ILM peeling area to increase that much. That is more than 3 cm, more than 2 cm. It is not mandatory. Just peel the ILM in a decent size. 2 cm is good enough to get the closer. Another thing is inverted ILM flap technique that we are routinely following this thing. Macular hole per se can cause retina detachment, but there is always probability of like peripheral breaks, like in this case. So here I stabilize the posterior pole without injecting the dye. Now using the soft tube cannula, I've gone inside and under the PFCL, you just start from the temporal disc margin, inject the dye. And this kind of approach will stain ILM better because the dye will be there between the PFCL and the retina. It will try to retain the dye under the PFCL, and then you can do the ILM peeling under the PFCL, sub PFCL ILM peeling, and just peel in an inverted peel manner. So inverted flap technique that will increase the chance of closure in case of macular hole with retinal detachment. It is very high, almost like 100% cases. Very badly you can get, even as a like the young generations, those who have already not done it is maybe their first case. If you are trying to peel the ILM in a detachment case, like with the help of PFCL, you can get this. If you can close the macular hole with the ILM, you will get 100% closure rate in your case. So you can increase the ILM peeled area, and then followed by fluid adduction through the peripheral brake, and do the vitreous base excision, followed by internal fluid drainage through the peripheral brake, and settle the detachment, and do all around 360 virus laser. Finally, cynic oil or gas at the end of surgery. When it was at infranasal brake, I put injected oil. So after 4 weeks, there is nice closure of the macular hole without you cannot see the ILM flaps. It's nicely closed. Another thing is surgery like inverted ILM flap technique in detached retina under PFCL, where I'm staining the ILM under the PFCL with the help of silicon tube backglass needle, starting from the disc margin going towards the macular area, and then slowly peeling the ILM. And gradually you can increase the size of ILM peeled area, and finally keeping the ILM tags around the macular hole margin, and just cover the macular hole with this ILM flap. Then you can increase the size of the macular ILM peeled area, and then followed by fluid exchange after doing vitreous base excision. And so after 4 hours of this surgery, you can see the hole is not closed, but still it is closing. You can see the ILM stuff inside the macular hole area, and after 3 weeks it is nicely closed. And if you follow up this type of cases, this is another very interesting case. Post diabetic vitrectomy, recurrent retinal detachment, open large macular hole where there is recurrence of retinal detachment in a combined retinal and diabetic combined RD, there are a lot of tractional proliferation happened, so that and secondary macular break, and as well as a lot of PVR changes. Patient came late, so a lot of PVR changes has happened, and whole margin is quite rigid. So how to deal this kind of case? Like I'm trying to remove the membrane, but retina is so friable and thin. I could have created a lot more breaks. So slowly I'm trying to remove all the rigid visible membranes after staining the dye, and finally finally there was a lot of peripheral traction also. So I had to do the 360 peripheral retinectomy to make the retina free from all the peripheral attachments, and finally injected PFCL to stabilize this central retina, and they used the curved scissor to take the peripheral retina, and with the help of this phenoceflex loop, I covered this ILM over the macular hole and cut the residual retinal tissue towards the periphery, and completed a 360 barrage laser, and finally used silicone oil. And after post-operative 3 weeks, you can see the island of retina, central retina is there, and you can see the hole is closed. So inverted ILM flap technique, improvement in BCV is significantly better than the inverted better in inverted flap technique, and primary closure rate also 100% in comparison to the non-inverted flap technique, like in 55.5% closure is happening, and no significant difference in the retinal detachment. Redetachment rate is there in both cases. Thank you.
So nice presentation, Dr. Badal. And suppose if you don't have PFCL in OT, then what is the choice of ILM peeling? How you can proceed with ILM peeling in detached retina?
You have to make it sure the PFCL should be available before starting the OT.
So
like anytime you can do the ILM peeling like without using PFCL.
It's a difficult procedure, but it can be done.
It can be done. It can be predictably covered. Otherwise, you can create much more elevation, retinal elevation from the macular area. You can create the break formation from the.
So you have to be very careful while picking up the ILM in detached retina. You can tear the retina and make the macular hole more larger.
Actually, not in your IC, but I'm telling you, when there is ERM as well as boggy macula, like in diabetic ERM, too much of fluid is there in the and overlying there's ERM. So you have to remove the ERM for injecting the. You have to remove the ILM also. In those cases, also, if you are using PFCL in any boggy retina, in any boggy where there is big serous detachment in the macula, you can just confidently do the ERM removal ILM peeling. So it is not. There is no hesitation. There should not be any kind of hesitation using PFCL. It should be used liberally. It is a real friend, like Rupak Kanti Biswas. Rupak, please.
Dr. Badal, what he told is absolutely correct. But with the Dr. Nandi's answer, if at all, if the PFCL is not available or sometimes, then the other option is that you can, in fluid presence, you can initiate the ILM flap and then do FGE. Under FGE, if your visualization is very proper, then probably you can, put the flap again into the hole. So that is now another way of doing it. But again, PFCL is the choice there.
Okay, our next presenter is Dr. Rupak Kanti Biswas. He will be presenting failed macular hole cases where the macular graft is the option. For his award-winning video, got the ASRS Best Video Award and Uretina Gold Award.
Dr. Nandi, thank you for inviting me for your course. But again, this is just to give you, I will show this, the technique of macular grafting, of autologous retinal grafting technique, which is very unique compared to the other technique. At the same time, I would just like to give you an, comparison of what are the things available for a failed macular graft. So what you can do with the failed macular graft, what are the things available, and how you can compare with those two. So let us start with this. So this is a standard technique of, when you do macular hole surgery, preferably standard ILM peeling, but if you can do an inverse flap technique, that is, as Dr. Baral was telling, that is a better way out. But again, there is a lot of controversy which size to be, inverse flap to be done, and up to, it has been seen that up to 400 there is no difference between whether you do inverse flap or you do standard macular hole. There is controversy lies between 400 to 600, but more than 600, yes, the role of inverse flap technique is definitely much better than the conventional technique. So internal limiting membrane plug and gas endotamponade for recurrent and persistent macular hole. So this is Professor Rizzo has described this. But again, this is a standard what we do usually follow. They have here 9 cases they have shown, and all the cases were closed. So normally standard as of now we all use this. But again, this is, we are putting the only ILM part of it, which is actually ILM is a food process of your molar cells. So it is actually a fibrous tissue, nothing else than the fibrous cells. So what it causes initiate a fibrosis in that area and drags the macula of the peripheral area into the central area, but by this way it comes closure and rest of the part fibrosis occurs. So the scotoma becomes less, but whether is it a functional, that cannot, only ILM cannot regenerate a retina. So that is a logic. So this is a technique where you can peel. So if it is your case, you know how much peeling you have done, but in somebody's case, then it is difficult. Again, you need to do a large area of staining, and then try to find out. It becomes fragile, but again, try to plug it there. Now, treatment of large macular hole with internal limiting membrane, and they have tucked into properly into the whole area, so that there is no residual of those membrane is lying over the area. So there are in this ILM plug, there is 2 techniques. One, all the ILM they put it into the hole. Another one, they put it into the hole and some part remains over the margin of the hole, so that the dragging and the fibrosis occurs. So this is in the tuck technique what I am has been described here. So this is another way out is, these are all about the ILM plug. Now when there is no proper treatment, there is multiple treatment. So what is here? So there is another group, they have tried of modified foveal enhancement. I think you all have come across. I mean, they have in a large macular hole with the soft tip cannula, they just advance the whole margins so that they come closure, and then drain the residual fluid, and then fluid air exchange, gas tamponade. It worked, but again, not in all the cases. There is another option, is that lens capsule. So whatever is remaining in the eye, so whatever you take and put it there, the hole is getting closed. So lens capsule or posterior capsular flap can be filled up here. This is a technique, and this is a video which I'll just skip and I'll show it to you. This is by one of my friend, Dr. Manish Bapai. He has done. He had a case of retinal detachment with macular hole. Now the hole also closed and retina got settled. Now what happened after that? After 2 weeks, 3 weeks later, then superior, there was some area of retinal detachment restarted, and he advised for surgery. Patient came back after 7-10 days, the whole retina got detached and the macular hole again reopened. As usual, what we usually see. Now, he had done a large peeling in the initial phase itself. He knows it very well that I have done adequate amount of the peeling and put it there, so the residual ILM is also not there. So what he did, he has to, take out the posterior capsule with the scissor and forceps. Yeah, so with the scissor and forceps, he just cut the posterior capsule, the large area, and then tried putting it there. And yes, obviously, hole closed and the retina got settled. So this is another way. So everywhere you can see it here, this is a whole area is completely a fibrosis. There is no retinal tissue per se as such. Yes, the hole is closed, the retina is settled, We got it, but again, that is what we usually looking for is not the way out. Now, human amniotic membrane plug to promote the failed macular graft. Yes, that has been also been tried with, by a lot of, Professor Rizzo has tried with this. They have shown that successful closure here, but again, you can see that there is a subfoveal fibrosis in this area as well. Now, another is there is a comparison has already been done by Dr. Naresh Babu from Arvind, and they have done a platelet-rich plasma with comparison of inverted ILM peeling for the large macular hole, which is comparable to the failed macular hole kind of situation. So their conclusion is that almost both platelet-rich plasma is equally effective compared to the inverted flap technique. So in either way is okay for it. Now comes to the autologous retinal sensory free patch transplantation for the persistent macular hole. So this is a technique which little different from the other autologous retinal transplant technique, because there the free flap is much more larger in size to put into it. Here I have devised a kind of a retinal trifine with which you measure the preoperative macular hole, and you see this area here. This is just simply you are refining the superior above the arcade superior area of the retina. Yes, this is not architecturally, and the cone concentration is not as good as like normal retina, normal fovea, but yes, it is a retinal tissue. So it has some amount of the photoreceptor cells and the neurosensory retina as well. So you can see it here very properly. This refining has been done in fluid. And then when this transplant, this is the graft, you can see it very clearly. The transplant is being, from here to graft is being placed over the macular hole area. And with the soft tipped cannula, just tuck gently. But at this time, you need to be very careful that your port should not be open. Otherwise, this can be sucked in. And then slowly, in a controlled way, you can, surrounding fluid, you can take out. Then donor area has been lasered and gas tamponade. Now, the difference between the other autologal ART and this, here we are using we measure the retinal, the macular hole size, the recurrent macular hole size, and then add up around 15% of that. So suppose if you have a 600 micron size of the failed macular hole, so you will take the trifine of 700 size. So 15% of the increase, this is in my initial stage. I used to use the same graft size. Then I realized that the graft shrinkage is occurring, and most of the time the graft is remaining within, and there is a surrounding area of remaining, a rim of macular hole is remaining. So then we have, when we have increased to 15% of this, then this is working properly and very well. Now this is a failed macular hole case where, after grafting, this is 6 weeks post-operatively, you can see the graft is very well placed, and the end-to-end attachment is also very nicely organized way you can see it off. So this is OCT. How functionally it is active? This is a comparison between, this is a normal foveal threshold of a multifocal ERG. So what we did it here. And this is the normal fovea. And next is, this is a standard ILM peeling technique by which the macular hole is closed. This is a primary closure. And this is with the failed macular hole with ILM plug. And this is your macular graft. It has a significant amount of the spike. So you can compare all in one chart. This is normal, this is repeeling with plugging, this is classic peeling, and this is grafting. Okay, so now this is, there are again, this is another, they have put the autologous blood inside, and then over that they have put the neurosensory retina. Again the debate comes whether the neurosensory retina over below there should be a blood or not, because blood again can degenerate the photoreceptors. So again, I'm not going into the debate of that, but this is another technique to hold the retina properly in the place. So now, another evidence that yes, this graft is functioning, whether the vascularization of the graft and the attachment, this is the proof what I'm going to give it to you. So this is another case of, this is post-operatively 3 months after that. This is a fluorescein angiography showing vascularization. This is 6-month OCT, This is 6-month octa is showing vascularization, but some amount. This vascularization is somehow taking a bizarre type of vascularization, not very properly, obviously. And this is 6 months of fluorescein angiography. And another case of this is octa at baseline. This is OCT as baseline. This is 6 weeks. This is 6 weeks post-op, and this is 3 months graft vascularization. Similarly, this is a large size. This is more than 300, 3,500, 3,400 size of the macular hole, which also got vascularized with this autologous grafting. Thank you. So probably this is the way forward for recurrent macular hole or large macular holes.
Nice bouquet of cases, Dr. Vishwas. So, what is the success rate of, what is the complication you have encountered while doing autologous retinal graft? Because I have very poor experience. I have lost the graft. I have placed the graft under the retina. If the graft misplaced, I have to redo it again. So, what is your experience? How many cases you have to do before becoming expert in autologous retinal graft?
Not really, Dr. Krishnendu. Actually, yes, that's what I was telling. The first case had a subretinal migration because it was a smaller size of graft, so I had a subretinal migration. Second case, I had a graft loss. Third case, it was there, but there was a rim surrounding it. So after 3 cases, first case I did it way back in 2015, end of 2015. So then after that 1 year, I actually lost interest of doing it. So that it is actually whether it will work or not. Then 1 year, after 1 year, again I went back of those retrospective analysis, and then again thought, and then I have increased the size, and this was absolutely successful. Now coming to the complication part of it, yes, this is a very simple technique, because there is a after around at 250 micron size, the 250 micron from the tip of that trephine, there is one more catch is there, so that even if you press it, it will not go and hit the choroid. But it is very difficult, believe me, to hit choroid, because the feel of retina and choroid is completely different. So it is very easy to differentiate, and there is only possibility is bleeding. The most common complication is graft loss, and second is some amount of the bleeding and oozing. But in a proper way, if we do it of initial trephination under saline and then graft placement in air.
So the catch is you have to have the trephine. You should get patented the trephine and market it. So that
it is available. It is available. It is available.
By experience.
Yes.
Like I have faced one case of graft loss in a like open macular hole case post surgery. So I put it under oil. So I redid the surgery. Again I took the graft, and the second time the hole closed. Second complication what I faced, that I placed the graft, and after I put him on SF6, and after this thing 2 weeks, 3 weeks, the patient came with partial attachment of the graft here, and I don't have the video and OCT. I have the OCT, and the graft margin is elevated like this. The hole is, like you can see, the hole is there and graft is partially attached, and the other margin is lifted up. So I just did FGE and tried to reposition. While repositioning that flap area, I realized the other part of the graft was so firmly attached to the RP. I cannot move it at all. It was so much, it is very firmly, it is maybe like normal retina, it is attached to the underlying base of the RP, base of the macular hole. It is very firmly attached. I cannot move that, graft from the other part of the RP. And finally did the FG and aspirated the fluid under the graft and put him on SF6, and finally the hole closed.
See, the experience what he is describing exactly the same, because once the vascularization occurs, then it is an integrated tissue. So you cannot differentiate unless until you cut it. It is not possible.
Extremely difficult to remove the graft from the whole margin.
Because this is a part of it is integrated into that retina. So it is not possible to differentiate between those two.
So it means it's definitively it's getting incorporated in the retinal tissue. So it's definitely useful if you have learned the trick.
Again, become 10 years.
Yes, it can become 10 years.
Any of these patients, later OCTA was done to see whether phobia is becoming vascular or not.
Those reports are there.
So we have this vascularization.
So even if you see the MFERG peak is much better than the conventional closure.
So doing OCTA.
Yeah, but this is one case just to show you. But may not be the all cases you can have that kind of a similar peak. But yes, this is probably the way forward that you can close the retina in a failed macular, close the hole in a failed macular graft. I mean, failed macular.
Which is the ideal site of taking this graft? Because the nature of the retina differs from the central and the peripheral.
I completely agree with you, but again, I will not prefer within the arcade, because the arcade, the cone concentration will be more. But again, this is more risky because the scotoma patient will have the scotoma. And obviously, superior part is more preferable because you are putting the gas tamponade. Third is beyond the arcade, whether you are right-handed surgeon or left-handed surgeon, depend on in which eye you are operating. So you need to be comfortable enough to refine that part.
So which part do you prefer?
So if I do it
You being a right-handed surgeon.
Yeah, if I do a right eye, I'm a right-handed surgeon, so I will prefer in the supratemporal area. So it will be somewhere around, not exactly on the, foveal line. If you draw a vertical line, slightly towards the temporal side of that.
I want to add a few more things. Like fovea has the maximum cone concentration. It's almost 0 rod cells. And the other part of you cannot compare fovea with any other part of the retina. So fovea has a 0 motor value that we cannot get from any part of the retina. So preferably where he's taking graft from the supratemporal area, I'm taking graft from the slightly supranasal area, not exactly the supratemporal disc, slightly supranasal vessels jahan se ja raha hai, udhar se. So from that area only I'm taking the graft. So wherever you are possible, but don't try to avoid the infrared.
Okay, with that I came to the last talk of the topic, this IC. So last topic will be covered by Dr. Somen Mondol. Unfortunately, he is not here available due to some family engagement. So I'll be playing his video. This is a sound.
Very good afternoon. An intraocular foreign body, when located near the macula, has a high possibility of macular damage during removal, and in some cases, the removal of the foreign body may cause greater A very good afternoon. An intraocular foreign body, when located near the macula, has a high possibility of macular damage during removal, and in some cases, the removal of the foreign body may cause greater retinal damage due to excessive fibrosis after surgery or due to retinal attraction. It is also a known fact that location of the intraocular foreign body in the posterior pole is one of the most important predictors of worse visual outcome in intraocular foreign body. Now, ideally, the removal is done at the time of repair of the entry site or soon afterwards, because an inflammation that is caused by the foreign body rapidly causes fibrous capsule all around it, which makes delayed surgical removal difficult. Now, the timing of intervention is primarily determined by the risk of endophthalmitis. The wound, however, should be closed as soon as possible. But there are some advantages of delayed surgery, sometimes because of inaccessibility to appropriate specialized resources. The surgery has to be delayed. Sometimes it's difficult to insert a 23 or a 25G trocar. A sealed or repaired globe actually allows for better insertion of a trocar cannula, and there is a decreased risk of uncontrollable hemorrhage. And often there is a high rate of separation of posterior vitreous, which makes complete removal of the vitreous easier. Now, the surgical goals are to clear the ocular media through removal of cataractous lens, through removal of the vitreous hemorrhage. Then we remove the vitreous scaffold from the scleral laceration site. Then the posterior haloid is removed, which could provide a future scaffold for epiretinal membrane formation and traction. Also, the retinal breaks and detachment are to be identified and treated. Now let's come to the cases. The case number 1 is a 47-year-old gentleman where there is a metallic intraocular foreign body in the left eye. Vitrectomy is done. The embedded foreign body is tried to be dislodged from its point of impaction. Hemostasis achieved. The foreign body is brought above by a magnet and a forceps. As we can see, the point of impaction is very close to the macula. Fluid exchange was done. Retina. Pores closed. And this was how the retina looked like in the postoperative period. As we can see, there's a significant amount of fibrosis with scarring. So we will discuss a magnet. Dislodging an impacted foreign body can be tricky, and utmost care is to be taken to save the macula as much as possible. For a non-magnetic intraocular foreign body, a proper forceps can be used. These are some examples of the intraocular foreign body forceps. The one on the left hand side is the claw that had been designed by Dr. Bapai, and on the left hand side we can see the various intraocular magnets. Now, following the foreign body removal, a thorough peripheral vitrectomy is performed, and in case of an associated retinal detachment, a complete vitrectomy is to be done. The retinal tears, retinal detachments are to be treated, taken care of, and tap on it is either with gas or silicone oil. If there's concomitant cataract, a cataract surgery with primary IOL insertion is done. And if the foreign body removal is planned through a limbal incision, then the patient is left aphakic for the time being. Now let's come to the second case. This is also a 46-year-old gentleman with a history of glass projectile in a glass blast injury, and we can see the glass foreign body in the left eye. Again, a huge amount of hemorrhage. Retina is found to be incarcerated at the point of insertion. So the surgeon is trying to disengage the retina. As we can see, there is associated retinal detachment inferiorly. Carefully, little by little, the surgeon tries to disengage the retina from the point of insertion. Hemostasis achieved through endocautery. Even after a considerable amount of exploration of the wound, the surgeon could not reach the glass foreign body because it seemed to be impacted deep into the sclera. Further digging would have caused more harm. So the surgeon decided to lift the foreign body as such. And after achieving attachment of the retina, laser was done. Case 3 is a 35-year-old gentleman where the CT scan shows a metallic intraocular foreign body. Again, the foreign body is seen to be impacted into the sclera, and that too quite deep. Even after a considerable amount of nudging, it turned out to be quite difficult to dislodge the foreign body from the point of impaction. So the surgeon now decided to give a few cruciate relaxing incisions so that the foreign body can be disengaged.
Like in this case, it was totally impacted in the retroorbital space,
And he could do so at last.
there was no more option was left because I cannot lift the eye with open.
It turned out to be quite huge.
This lot of difficulties with surgery, like lot of hiccups.
The limbal incision was broadened, and with the help of a magnet, turning the foreign body along the long axis, finally it was out of the eye. Hemostasis was achieved following fluid exchange, laser photocoagulation. Silicone oil was injected, and after a gluedival implantation after 5 months and after silicone oil removal, the visual recovery was quite extraordinary. So now with a high brightness xenon light source, use of chandelier light source, and use of wide angle indirect ophthalmoscope viewing system, the management of intraocular foreign bodies have become a little easier than what it was before, and it now improves the ability to save as much of the macula as possible in quite a hopeless situation. Thanking you.
So at the end of the instruction course, I like to ask if you have any question we like to answer. Otherwise, we'll close the session. We like to thank our speakers yes, Dr. Anindya Maiti, Dr. Rupakanti Vishwas, Dr. Shubhendu Boral, Dr. Sudipta Das, myself, Dr. Krishnendu. Thank you for your patience hearing. To see you back again in next year in AIOS Kolkata. I would like to invite everybody, especially, to come and join in Calcutta next year.